My colleagues, I'd like to introduce you to our next speaker. Our next speaker is Professor Ahmed BaHammam, who's a consultant pulmonology and sleep medicine. He's the director of the University Sleep Disorder Center at the King Saud University Medical City. He's also the executive director of the academic affairs at the King Saud University Medical City. Professor Ahmed BaHammam is established the first academic sleep center in Saudi Arabia, 2001. And for myself personally, he's a great teacher when it comes to sleep disorder breathing, and a personal friend of mine that I always enjoy listening to. He has published so many articles in the field in the most pronounced international journals. Today, he's going to spend the next 20 minutes telling us about sleep disordered breathing. Professor Ahmed, so good to see you, and assalamu alaikum.
وعليكم السلام ورحمة الله وبركاته. صباح الخير بروفيسور أشرف. Thanks for the invitation. جمعة مباركة عليكم جميعا. I'm sorry I'm out of town, but as I'm trying inshallah to give a simple talk but informative. I enjoyed Dr. Saba's talk, mashallah, very good, very impressive, mashallah, very impressive and informative. Okay, so we'll talk about introduction to sleep disorder breathing, and I will focus mainly on obstructive sleep apnea because of the time limit. If I have time, I'll show you two videos quickly. I have to share them after stop sharing and reshare again. Okay. I don't know, the slide is not changing. Okay. This is what we call normal breathing. These are 2 minutes window of a sleep study for epochs. Between a line and line we call epochs. So I want you to focus on the pattern of breathing. This is the flow, here 2 channels, and this is a thoracic and abdominal wall movement. You see things are going homogeneously in phase, very nice breathing. These are the other signals, you don't have to worry about them much. And this is the oxygen saturation, you can see 96, this is normal breathing. And this is also another example of normal breathing. You see the flow and the effort are going in phase, nice, and the saturation is also stable. These are examples of normal breathing, and this like 30-second epoch. A normal study for the whole night, maybe like 800 epochs. So when we say sleep disorder breathing, this is a term that encompasses not only obstructive sleep apnea, but central sleep apnea, obesity hypoventilation syndrome, and respiratory related sleep disorders in patients with asthma or COPD. But in this talk, we'll focus only on obstructive sleep apnea because of the time. So when we say apnea, for adults, it's cessation of airflow for 10 seconds or more. For children, it is less because children breathe at a faster rate, sometimes at 30 per minute. So in children, if they miss 2 normal breaths, that's apnea. For adults, it's 10 seconds or more. This is the definition of apnea, and it is cessation, complete or almost complete cessation of airflow. So it is an easy example. It's easy definition. On the other hand, hypopnea is a more difficult term to define. There is, you can see here, there is a reduction in flow. This is normal flow, normal effort, and there is a reduction here. This is called hypopnea. Again, has to be 10 seconds or more, but has different definition. I will not go into the details of that, but you have to know that there is something called apnea, which is complete cessation, and then hypopnea, reduction. And you see desaturation. When we say apnea, there are 3 types when we score the study: obstructive events, central events, and mixed events. So if you look here, there is no flow. So if there is no flow, complete cessation or almost complete, we call it apnea. So all of them, there is no effort. In the obstructive, the patient is trying to breathe. There is effort, but no flow. So this is obstructive. The airway is closed. The upper airway is closed. Mixed apnea, you don't have to worry much about it. Central apnea, there is no flow and no effort. So this is central coming from the brain. So this is the difference between obstructive and central apnea when we score. There are criteria to define obstructive sleep apnea, especially when you do research, publication, or when you claim from the insurance companies. I will not go through that because of time, but it is in the slides. You can review it because I think slides will be shared with you. You can look into that. I will, for the sake of time, I'll skip that. So then how do we score the severity of obstructive sleep apnea? There are different definitions and disagreement among experts, but what's accepted now is what we call the apnea-hypopnea index, which is the number of apneas and hypopneas per 1 hour of sleep. So if a patient slept for 10 hours and they have 60 apneas and hypopneas, we divide 60 by 10, then the apnea-hypopnea index will be 6. If they have 60 apneas and hypopneas and they sleep for 6 hours, then 60 by 6 is 10. So the apnea-hypopnea index is 10 per hour. It's an index. Normally, it is less than 5 in adults, mild 5 to less than 15, moderate 15 to 30, and severe more than 30. In children, it's more than that. Up to 2 apneas is considered abnormal because children, as you say, they have different respiratory rate. What are the symptoms of obstructive sleep apnea? Snoring is the cardinal symptom. And the prevalence in different countries have been reported, including our region in Saudi Arabia and United Arab Emirates. I'll show you data from Saudi Arabia, which is almost the same like that in Emirates, same population. So snoring in middle-aged men in Saudi Arabia, it's around 50% of those who know that they snore. Some of them, they snore and they don't know. This is comparable to that in the West. What's higher than the West is women. Snoring among middle-aged Saudi women is high, up to 41%, and this is attributed to obesity. Obesity is very common in our region. It's improving now. This assessment was done using a questionnaire called the Berlin Questionnaire, which categorized the risk of apnea or obstructive sleep apnea into high risk or low risk. So the high risk for obstructive sleep apnea among middle-aged Saudi men is 30% or 3 out of 10, which is comparable to that in the West here. What's surprising was that for women, around 4 out of 10 middle-aged Saudi women, they have high risk of OSA, so sleep apnea. And in Lebanon, a recent study, also our colleague in Lebanon, AUB University, also they had similar things. Again, why is that? Because of obesity among middle-aged women in our region. High risk doesn't mean that they have OSA. It means that they need assessment, probably they have OSA. In this study, our colleague, Professor Siraj Wali, he took those with high risk and did for them sleep study. And the prevalence among middle-aged men in Saudi Arabia of OSA, not risk, is 11% and 4% among middle-aged women after doing proper sleep studies for them. Snoring can create major domestic problems. I have seen couples who get divorced because of snoring. And almost every day I see couples in the clinic who sleep in separate rooms because of snoring. So snoring is not a benign problem, even if there is no apnea. Daytime sleepiness is not present in all patients. Maybe 30% of patients with OSA, they will have daytime sleepiness. Those with daytime sleepiness, probably they have more complications and they have also better adherence to treatment like CPAP. But daytime sleepiness is not caused only by sleep apnea. The commonest cause of daytime sleepiness is insufficient sleep. Other causes include medical and psychological disorders and medication. So you have to check for that. Nocturnal choking and gasping, this is what brings most of the patients to the clinic. They come because they have choking. As this feeling is really one of the worst feelings that a patient may get, and they come running to the clinic. They have also other symptoms that I'll go quickly over it. Witnessed apnea, the bed partner may see that. Nocturia, meaning that they have to get up at night to go to the bathroom. Most males will come, they think it's related to prostate or diabetes, but obstructive sleep apnea is one of the common causes of nocturia, which is under-recognized. Nocturnal sweating, morning headache, dry mouth on awakening, nocturnal heartburn, nocturnal chest pain, refreshing sleep, decreased memory and concentration, impotence among men, symptoms of depression, and nightmares or excessive dreams in patients with REM predominant OSA. They feel that all their sleep is dreaming. Of course, not all patients will get all these symptoms. They may get some and may not get the others. There is a special entity called REM predominant OSA. This is a recent paper that we published. You can check if you are interested. Just in summary, this REM predominant OSA happens mainly in women and young adults. And we found here that it is also linked to asthma. We know that sleep apnea is common among asthma patients, and asthma is common among OSA patients. And among those with asthma, REM predominant OSA is more common than non-stage specific, which means that it happens in REM stage and non-REM sleep stages. If I have time, I'll show you quickly a video of, I'll stop sharing here and try to share the video. I already opened it, of a sleep apnea. Okay. Why it doesn't appear? Screen mirroring zoom on your iPhone. What is this here? I don't know what happened.
Okay, Professor, when you make sure that the video is already open, and then when you click on the share screen, below there's a check mark for the enable sound.
I had some videos which were in the screen, but unfortunately I don't have consent to put it in of my patient. I don't have consent to put it for online. So I try to get other videos which is have consent for online as well. So I'll try to share it again. If it doesn't, I'll go to my slides. Yeah, this one. Okay. Okay, I hope you can see it.
Yes, we can see it.
I don't know why it doesn't start. Can you see it?
Yes.
See, this is a patient with obstructive sleep apnea. You see the patient here. He was awake and breathing or had arousal. Now he has apnea. He's not breathing. You see now the paradoxical movement in the chest and abdomen. When we breathe, usually chest and abdomen will move outside together because the airway, the upper airway is closed. Then when he tries to inhale, create negative intrathoracic pressure, the diaphragm is moving down to pull air, but the chest will be sucked in. You see the paradox? There is paradoxical movement. Patient is asleep now, trying to breathe, but there is no flow, complete cessation. Now, big snort, and he starts breathing again. Okay, I'll try to share the slides now and stop the video so it doesn't disturb you. Okay. Sorry, I'll try to do things quickly. I'm sorry, it's getting complicated for me. Okay. There's a video at the end, but I don't have time for it. But if we have time, we'll share it as well. Okay. So how do we assess for daytime sleepiness in the clinic? There are different ways. One of the common way to use is what's called the Epworth Sleepiness Scale, which assesses sleepiness over the past month and asks people about common daily living situations and 4 chances: no chance of dozing, 0, slight chance of dozing, moderate and high chance of dozing. The total score is 24. What's acceptable that if you score 10 or more, that's daytime sleepiness. We have the Arabic validated version of it. You can get it from this one. And if you like, I can share it with you. You can email me, but you can get it from this one. How do we assess for, or we screen for OSA in patient coming like for surgical procedure, or if you are a GP, general practitioner, you want to screen for that. You can use one of these questions, the stop bank questionnaire: snoring, tired, observe, pressure, body, age, neck, and gender. This is for the stop bank. This is a validated Arabic version of it. You can use it. I can share it with you. It is published online. Or we can use the Berlin questionnaire, which is also another questionnaire that can be used for screening and validated. It is more complicated than the stop bank. This Arabic version of it also, I can share it with you if you like, or I can put it for you, or you can get it from this one. Just copy it from this one. So what are the risk factors for OSA if you get a patient with OSA? Short, fat neck in women 16 inches or more, men 17 inches or more, increase the risk of OSA, even more important than body mass index. Even for bodybuilders, if you get your neck thick, you have higher risk of OSA. Small mandible, because I'll show you some radiographs now. It takes all the soft tissue and the genioglossus muscle, a big muscle here, take it back close to the posterior pharyngeal wall, make the airway narrow. Retrognathia, you know we have something called nasion and something called gnathion. And if you draw a line here, this is the nasion and the gnathion. You see there is retrognathia. Again, take the tongue and soft tissue in the throat backward to the pharyngeal, toward the posterior pharyngeal wall. Overbite, a small mandible, usually less than 3 millimeters between upper incisor and lower incisors. When you get 3 millimeters or more, this means that you have, the patient has retrognathia or overbite. So it will move everything backward of the soft tissue. In children, when you examine them, most of the time they will have tonsils and adenoids. That's why in children, adenotonsillectomy usually is the treatment of choice, and it's usually effective in more than 90% of the patients. In adults, most of the time you don't see tonsils and adenoids, but you may see it occasionally. So we have to check the throat. You may see people in their 50s with what they call kissing tonsils or tonsil 3, level 3. You are surprised how they stayed with this large tonsils for these years and no one looked at their throat. Most of the time you see lateral narrowing and elongated uvula like this photo. You may see large tongue in some patients. And when you say large tongue, you have to be careful because patients in Saudi Arabia or in Arab countries, if you tell them large tongue, they may get angry because it's not good to say to someone you have lisan kabir or shay. So it's actually relative. They may have a small mandible, so the tongue will be relatively large for the mandible. So not necessarily that they have large tongue. You may see the teeth marking, as you can see here, the teeth marking on the tongue, which may reflect large tongue, like in patient with hypothyroidism, for example, or genetically, or small mandible. This is the airway normally. You can see here the airway. This is the tongue, the genioglossus muscle, the uvula, and soft palate. And this is a patient with sleep apnea. When they sleep, tongue will go backward and will touch the posterior pharyngeal wall, causing closure. And if the mandible is small, everything will go backward. So in patients with obstructive sleep apnea, you have always to check the upper airway, and you have to check their blood pressure. By the time they present to us, probably 50% of them already will have hypertension. By the time they present to us patients with obesity hypoventilation, more than 70% of them, they will have already pulmonary hypertension, the sort of dysfunction, and almost 100% of them, they will have hypertension. So don't miss that.
Professor, I just want to draw your attention to the time. We have 1 minute, please.
Okay. Okay.
Thank
so
you.
I will go to the treatment then. This is example of sleep apnea. Treatment, general measures usually do not work, like for patients. Most of them are overweight, so weight loss, bariatric surgery may help, but weight loss is difficult for them to lose weight. Those with the positional apnea, like only when they sleep on their back, they have the apnea, you may help them with some techniques, like having tennis ball or some sensors, vibrator that will help them to sleep on their side. Then we have specific measures like boosted airway pressure, intraoral appliances, surgical treatment, and hypoclosal nerve stimulation. I will not talk about surgical treatment because this needs a special talk. I'll cover briefly about CPAP. This is like an example of CPAP, non-invasive ventilation, which will open the airway. The airway is closed here, as you can see. CPAP will act as a positive splint, airway splint, so it will open the airway, will allow air to go in. Also will increase the functional residual capacity of the lungs, so patient can sustain even hypopnea or apnea for longer period. CPAP has been shown to improve quality of life, improve the partner sleep, improve daytime sleepiness, decrease motor vehicle accidents, improve hypertension, and also increase ejection fraction, improve insulin resistance, and decrease inflammatory biomarkers. If you have good follow-up, this is a one-year follow-up of patient in Saudi Arabia on sleep with sleep apnea and CPAP. By the end of the year, more than 80% of them are still using their CPAP if you have good program for education and follow-up for them. I'll skip this video for the, you have now different masks that can provide comfort to the patient and interface. I'll show you the mandibular advancement devices quickly. For young people with moderate OSA, if they have small mandible, they can have some oral appliances like this. The airway is closed here. It will push the jaw forward, so it will open the airway. You see the airway here is closed. By applying putting the appliances, pulling the jaw, you see the jaw here is small with the upper incisors before the lower incisors. Pulling it forward, you see the airway open, so they can put it at night when they go to sleep. They can do also surgery, maxillomandibular advancement surgery, where they move the maxilla and mandible forward. You see here there is retrognathia, and this is here after adjustment. It's okay. Recently, they have the hypoglossal nerve stimulation, which is a pacemaker under the skin with a sensor that can feel the intercostal muscle contraction. And when it feels that, it sends a signal to the hypoglossal nerve to stimulate the tongue. So the tongue will move outward when the patient is inhaling. So it will open the airway and patient can breathe. And this is FDA approved probably 10 years ago. Some patients, they like it. Key points here, sleep disordered breathing is an important medical disorder that warrants active investigation by means of clinical evaluation and polysomnographic sleep studies. Treatment is essential not only to improve the symptoms that include sleepiness, but also to prevent the development of cardiovascular complications. Effective treatment exists that includes behavioral, medical, and surgical means. Dramatic improvement in patient well-being can be achieved. Thank you.
Thank you very much, Professor. يعطيك ألف عافية. ما قصرت. I totally agree with you with regard to the social distress that obstructive sleep apnea or sleep disordered breathing can impose on families. And, I did come across people, especially in the excessive extreme of it, such as cases of narcolepsy, where divorce and separation did happen. And I did come across partners who were accusing the other side of just being lazy and sleepy, and that they're not worth taking care of the kids and the family, and separation happened. And it's, alhamdulillah, good enough that I saw after treatment, the couple go back together. It's amazing what this disease can cause sometimes on the social side. A couple of questions for you, Professor. I noticed that you did like really to come to the oral appliance, although this is not for us as pulmonologists. We refer to dentists usually to design them. Why are you so keen in them? Did you see in our region better compliance or outcome with oral appliance as opposed to CPAP, when people usually talk about the CPAP having higher efficacy for sleep disorder breathing as compared to oral appliance? Or is it operator dependent and design dependent?
In general, studies have shown that oral appliances probably they have the same adherence as positive airway pressure or CPAP. However, some patients, they don't like CPAP at all. Whatever you like recommend for them, advise them, they will never use CPAP. CPAP remains first line treatment. We have surgical treatment and mandibular advancement device as alternative or plan B. The FDA has approved what we call MAD-MAD for mild to moderate OSA, especially in young, thin patients. So we have patients who go for that, especially those who refuse. We try with CPAP. If they refuse CPAP completely and they have like overbite, thin, young, we go with the alternative like MADs. MADs, just have to mention here that it is the idea is simple, but the application is not simple. It needs specialized people, and probably if you remember, I put some geometric measurement. They have to do their own measurement trained dentists and appliances who will do the measurements and then design the appropriate device. One thing also that after these devices are fitted there and are in use, we have to repeat sleep study. These are the recommendations to make sure that there are no more apneas during sleep. We have patients who use them. Also, they are not completely without side effects. They have their own side effects, which are usually discussed by the dentist.
Sure. I want to ask you about your statement on increased risk of obstructive sleep apnea with obesity. How much weight should the patient lose, and how much percentage of the weight loss impact on the apnea-hypopnea index?
Of course, we have to mention that OSA is a genetic disorder like diabetes, for example. I tell my patient that, listen, you may see an obese subject of your age who has no diabetes, and you get diabetes once you gain weight. Same thing for OSA. There is a strong genetic component. So not all obese subjects will have OSA, but if you have the genetic predisposition and you gain weight, then you are at higher risk of OSA. Losing weight may result in improvement. Even minimal weight loss, like 10 kilos, for example, you may have significant improvement in OSA. But in general, if you look to data from bariatric surgery, 60% of patients after doing bariatric surgery and reaching the optimal weight that have been agreed, or the target weight that have been agreed with the obesity bariatric surgeon or obesity physician, 60% of them will still need CPAP. So losing weight doesn't guarantee that OSA will disappear. It may disappear in some patients. In others, it may improve, but may continue. That's why when the target weight is reached,
losing weight
and then assess if they still have apnea or not, whether they need treatment or not. Another important point, that not all OSA patients will be obese. 70% of OSA patients are obese, 30% may not be obese. Some of the worst apneas that I have seen in my practice are in patients who are thin, but they have small mandible or maxillofacial abnormalities.
And last question, Professor, and that is with regard to the hypoclosal nerve stimulation. Is this available outside clinical trials in our region as a treatment?
It is available. It has been approved by the FDA around 10 years ago. I have one of my patients who's using this device. He didn't like CPAP at all. And then he went to Stanford Clinic where he did maxillomandibular advancement surgery, though it is done in Saudi Arabia, but he preferred to go and do it there. They told him that everything is fine. When he came back, I told him, come back to do the study. We did study for them, we found no change. They told him that we are fine. So he went again and he did this hypoglossal nerve stimulation, and he's using it now probably for 8 years. We have a surgeon in Saudi Arabia who is also trained in that. I don't know if he started that or not, but even the long-term complications so far, like after 10 years, is safe. I have seen patients who complain of pain after some time, pain in the tongue if they use it. Just in brief, it has a remote control. So the patient will point it with the remote control to his chest and start the device. The device, you can program it to start, for example, after 30 minutes from the click. So by the time you go into sleep, it will start. But it doesn't look good if someone is sleeping beside you, because your tongue will be coming, if I just mimic it, if this is the mouth, the tongue will be coming out. I don't know if you can see that now, sorry, but the tongue will be coming out. When you breathe, it will come out. So it will come out to open the airway, then it will go in. And if it is active, when the patient is awake, his speech will be slurred because the nerve is stimulated. So he will have slurred speech. That's why it starts after they go to sleep.
Thank you. Thank you very much, Professor. Thank you for giving us your time while you're outside the town. And
thank you very much.
Pleasure to be around with you. Thank you very much.
Thank you for the invitation. Thank you.